which we'll go over in a second. Pregnant their labor will feel and how they can manage it. It's hard to start, I feel like, right? Labor is going to be different for every individual, and it can also be different to the next. So, power to avoid being transferred to, within their first trimester or so. There's exercise classes. There's infant care classes. There's people who have never touched a baby, until they have their own. So learning how to do things like put on and swaddle and dress and use both syringe are all helpful for people who don't have any experience with infants. Breastfeeding classes, sibling classes, grandparent classes. There's classes geared towards adolescents, which may be more comfortable for them than being in a class full of a bunch of older adults, because they're with peers. There are refresher classes for somebody who's maybe already had a baby and just needs some little tips and reminders. There are C-section birth classes for women who know that they're going to have a C-section. That can help kind of prepare them for what to expect in the delivery room when it comes to a C-section. We'll talk more about C-sections in Chapter 8. Women who are desiring to have a vaginal birth after a C-section, also helpful to kind of know what to expect. And then adolescent classes, which we just talked about. And what they go over in childbirth classes, changes of pregnancy, what to expect going forward, right? Changes in the body, fetal development, depending on how far along the mom is in the pregnancy, they'll talk about what's going on with the baby at that time. Prenatal care, all things to take your prenatal vitamins, good diet and exercise, things to avoid, hazardous substances to nutrition, common discomforts, about exercise, and then coping with labor and delivery. Okay, so how does childbirth pain differ from other pain? Well, it's going to end, right, at some point. At some point it goes away, and then you have the pain of the child for 18 years. And the headache, the constant headache for 18 years. It's part of the normal birth process. It's unlikely you're going to get out of it without any discomfort. Excessive pain is detrimental to the labor process. If you're in pain, what do? You tend to you're tense, right? You're kind of tightening up, you're uncomfortable. So, that can impede, how the contractions are working to help the cervix dilate. Pain can also be beneficial. If you're in pain, you're going to change positions. And changing positions and, rotating helps facilitate fetal descent. It helps that baby move down into the birth canal. Okay? You have several months to prepare for pain management. Limiting and rapidly declines after birth. Right? You think right before that baby's going to come out, I'm never doing this again. And then the baby comes out and you forget all about it. Always important to keep in mind that every patient's pain is individualized. And this is not just in labor and delivery. This goes for anybody. Right? How painful somebody feels a broken leg is going to vary from patient to patient. Right? Some have higher pain threshold and a higher pain tolerance.
Oh no.
Oh. Pain threshold is also called pain perception. It's the least amount of sensation a person perceives as painful. And pain tolerance is the amount of pain one is willing to endure. So they may be in an excruciating amount of pain, but they're willing to endure it. And this is more for if somebody's looking to have a natural childbirth without any pain medication. Okay, sources of pain during labor, dilation and stretching of the cervix, the contractions. Every time the uterus contracts, there's decreased blood flow, which causes ischemia to occur. Pressure of the baby on the pelvic structures, and then stretching of the vagina and perineum. Central nervous system factors, the gate control theory. This explains how pain impulses reach the brain for interpretation. So there is a theory that pain is transmitted through very small diameter nerve fibers, and that by stimulating larger diameter nerve fibers, you can close the gate control theory. This would be the rationale behind is having a lot of back labor, and they're in a lot of pain, lower back pain. Using things like sacral pressure or massage on the lower back, you're stimulating those larger diameter nerve fibers, and it's distracting from the pain of the contraction. Okay, so it helps to alleviate some of that discomfort. Endorphins are a natural body substance similar to morphine. Endorphin levels increase and kind of peak during labor, which explains why, maybe not a regular dose of pain meds are needed for moms in labor. They can have smaller doses. Maternal conditions that can influence labor. Cervical readiness, that pre-labor effacement and dilation. Okay, if that's all happening before true labor begins, then that can alleviate some of the discomforts that occur during early labor. Size and shape of the pelvis is going to determine how well the baby can descend through it. What's our optimal pelvic shape? The GYN one.
Right.
Labor intensity. I think in chapter 8 we'll talk about something called a precipitous delivery, which is a delivery that happens very rapidly within 3 hours from start to finish. And you might think, wow, that's awesome, right? So fast. But it's very intense. And everything that usually happens gradually over, 12, 18 hours happens in less than 3. So it's very intense. The contractions are very strong right off the bat, one right after the other. So short, intense labors are often more painful than a labor that's of normal duration. And then fatigue. You guys don't know what it's like to be tired, right? When you're tired, everything is worse, right? The littlest things that are normally not a big deal are so much worse. So the same thing in labor. And, in general, you're probably not sleeping that great towards the end anyway. So a lot of times moms are going into this already pretty tired, deficient in sleep. So coping reduced. Okay, the baby's presentation position. The fetal presenting part acts as a wedge to efface and dilate the cervix as each contraction pushes it downward. So abnormal position means uneven pressure, which means that less effective effacement and dilation, and a longer labor. If the baby is OP or occiput posterior, each contraction is going to push that baby against the mother's sacrum, resulting in very poorly relieved back pain. So ideally, we want the baby like this, occiput anterior. This part of the baby's head facing out. So we want baby facing mom's back. Interventions of caregivers, all the things that we think are super helpful can also cause discomfort. Putting in an IV, just having the IV line in, especially if there's fluids running through it, then you have tubing that you have to deal with. That can cause discomfort. Continuous fetal monitoring. Not that that's invasive or painful, but it can affect the ability to move around freely if you're tethered to a monitor. Amniotomy, the artificial rupture of membranes, and the vaginal exams. Not that they're the worst things in the world, but it's all right. And then psychosocial factors such as cultural influences. All right. So first, we will talk a bit about non-pharmacological methods of pain management. These can be used alone for a woman desiring a labor experience without medication or in conjunction with pharmacological methods. Okay. Advantages: there's no harm to mom or baby. Okay. They do not slow labor down if they provide adequate pain control and help keep labor going. And there's no risk for allergy or adverse drug effects. Most childbirth prep classes are based on one of several methods, and every time they're modified to meet the needs of that individual. Because you may teach them a technique or reinforce a technique that they've learned in the past, maybe during a childbirth class, but they may not find it to be helpful in that moment. Okay. The Dick Reed method, he was an English physician who introduced the concept of a fear, tension, pain cycle during labor. A mom who is scared of labor is going to have increased tension and increased pain. Okay, so keeping her nice and relaxed, using lots of relaxation techniques can be helpful in reducing her anxiety and fear and therefore decreasing the amount of pain that she's in. The Bradley method, this was also called the husband coach childbirth. It was the first to include the father as an integral part of labor. This one focuses on abdominal breathing and relaxation techniques. And then the Lamaze method, which is probably the most familiar, also focuses on different breathing techniques using mental imagery and focal points to help with relaxation. All right, we're going to go through some of these non-pharmacological pain relief measures. Helping the mom relax during labor. Can do that can help decrease some of her fear and anxiety, right? Before she even kind of gets fully admitted to the hospital. Orient her to the environment. And that's one of the things they do during a childbirth class. They'll have the moms tour the unit. They'll tour labor and delivery and they'll see like these are the rooms, this is a little refreshment area for your spouse or your support person to get drinks, snacks. This is the waiting room. If there's a possibility that the baby may go to the NICU, then they will also tour the NICU, because being able to see the environment can help you relax if you're not afraid of the unknown. The general layout. Explain procedures that are going to be done, right? And give her a reason, like maybe why something needs to be done. And being able to answer questions can help alleviate the anxiety and help her to relax. Keep the environment calm, to the best of your ability. Sometimes emergencies happen and everything is chaotic and it is what it is, but, try and keep her environment as relaxed as possible. Explain what's happening to her body and guide her to release tension. You have to be like a yoga instructor too, maybe. Be like, relax your shoulders, calm your body, those kinds of things. Cheerleader and yoga instructor. In stimulation, there's several variations of massage during labor. Okay, most can be taught even if they did not attend childbirth classes. So effleurage is the technique that stimulates those large diameter nerve fibers that can help close the gate for pain and discomfort from contractions. So with effleurage, the woman strokes her abdomen in circular movement during contractions. And that is what she's doing right here. And you do often see a lot of moms doing that when they're having a contraction, right? They're kind of naturally, without knowing, probably rubbing their abdomen. Sacral pressure is firm pressure against the lower back. This can definitely help with back labor. And that's what's happening here. It looks like he's got maybe like a tennis ball. That can help like a nice rolling action to happen on the lower back, and that pressure helps relieve some of the discomfort from the back labor. Thermal stimulation, heating pads. Some moms might like to use the bath or a warm shower. Those can help, if it's safe to do so with the discomfort of contractions. Frequent position changes help relieve muscle fatigue and strain and promote the normal mechanisms of labor, meaning it can help the baby descend through the birth canal. Changing positions helps that baby shimmy on down. Diversion and distraction. Several methods they use to stimulate the woman's brain. It could be a focal point where they just focus on something across the room. It could be a picture on the wall. It could just be a spot on the ceiling. Something to focus on during the contractions. Some may close their eyes and could have an internal focal point that they're focusing on. Imagery. Create a tranquil mental environment by imagining she's in a place of relaxed peace. You can practice that here. In whatever class is not your favorite. You can imagine you're someplace else. Music. Lots of women like music. TV. Sometimes it's just background noise. that's there for comfort. It's not that they're necessarily watching TV, but it's having that background noise playing in the background. Acupuncture can be helpful for pain. It's going to be a challenge, I think, to find somebody to do acupuncture while you're actually in labor at the hospital. There's nobody floating around just poking acupuncture needles into people, but acupuncture can help. All right, breathing techniques. These are more effective if practiced before labor. Shouldn't use them until they need them. She can become too tired if it's used too early. There's different types of breathing that can be done. With first stage breathing, this is breathing that moms can do during the first stage of labor, meaning all of labor. All of dilation and effacement is the first stage of labor. And then second stage breathing is used when pushing begins. With all of these different breathing techniques, it always begins and ends with a deep breath in and out. You don't have to know the details of the different types of breathing techniques, but they vary from slow pace, which is about half your usual rate, where you slow down your breathing quite a bit. Modified pace breathing is about twice the rate, so speed up your breathing. This one's the one that you usually see in people who are, pretending to have a baby on TV or in a movie, where they're doing that can't like that. Everyone, see beginning and end is a nice big plunging breath in and out. Okay. Now, with all these different ways of breathing, the thing that could happen is hyperventilation. If you know the symptoms of hyperventilation, then what to do for you is hyperventilate. So signs and symptoms: dizziness, tingling of the hands and feet, and muscle spasms and moving, especially when it's scaling. There's I think a lot of paramedics use this term too, but I've used it on the kids when they're having a tantrum when they were little. But smell the flower go out the canvas, right? And through the nose, smell the flower, blow out the canvas. Breathing into cupped hands, comparable to place a raised washcloth over for a few seconds before exhaling. Sources role in non-pharmacological techniques determine if the attended child is sick. If her water is broken already, then she has amniotic fluid that's just continuously leaking out. Keep those pads underneath her are kept dry. Don't get uncomfortable. Pharmacological pain management. Medications that we can use during labor and delivery. Okay, these include analgesics, adjunctive drugs to improve the effectiveness of analgesics or to counteract their side effects, and then anesthetics. Analgesics are specific about loss of consciousness. So this would be like the loss of the lidocaine they're going to be working on. So you will have no sensation in that one spot. General anesthetic is loss of consciousness and sensation. General anesthesia, you are asleep. Regional anesthetic in this case would be spinals and epidurals. We're numbing a certain area of the body, larger than if you have a root trauma. Two types of anesthesia clinicians, anesthesiologist, and a CRNA, which is a certified registered nurse anesthetist. Keep in mind some of the physiology of pregnancy and how it can relate to analgesia and anesthesia. We have a higher risk for hypoxia. That baby's putting pressure on the diaphragm, and taking those deep breaths can be challenging towards the end of pregnancy. Pain meds can depress respiration. So higher risk for hypoxia. Pain meds also slow down the GI tract. They decrease peristalsis. So your intestines are already pretty squished, by the end of pregnancy. So you become even more sluggish, increases the risk for vomiting and aspiration. Our aortal cable compression or our supine hypotension syndrome can happen. Blood pressure meds or pain meds can also decrease blood pressure. And that supine hypotension syndrome. So anytime we give a pain med, we have to think about what's going to happen to the baby. How is this going to impact the baby? Okay. So generally, pain meds are not given if it looks like the baby's going to be born soon, right? If you give mom a nice, healthy adult dose of morphine and she delivers an hour later, what does the baby have? A nice, healthy adult dose of morphine. So the baby's probably not going to want to do much. They're not going to want to do all the things you're supposed to do, like cry. Advantage of pain using them during labor allows the mom to be more comfortable and relaxed. Increased relaxation aids in her ability to work through contractions. It lessens that stress response. Okay, so it helps her pain, it helps keep her relaxed, it makes labor go a little bit more smoothly. Our limitations, again, we have to remember that 2 people are being medicated. We have to think about what's going to happen to the baby if the baby is born. After mom is in pain. It also affects the baby. And affects the mom. So if you give the mom a dose of morphine and her blood pressure drops, the baby's going to be affected indirectly. Because if mom is hypotensive, then the placenta is not going to get perfused. Generally not given early on in labor because they can slow things down. Then we're on board for the baby. Narcan is used to reverse respiratory depression, usually in an infant. And I think I don't know if we've talked about Narcan before. Then give it draw, which can be worse. So if the baby comes out and it's not it's supposed to, like cry and breathe, then that until the medication. So if that means the baby needs to have a breathing tube in front of the ventilator for an hour or 2 until the medication wears off, then that's what usually happens. Narcan will not reverse respiratory depression caused by intrauterine hypoxia. So if there's something that happened in utero, like some type of event that happened in utero, and that's the reason the baby is not reactive, Narcan is not going to do anything for that. Adjunctive drugs are not pain relievers, they're given to treat the side effects. So pain meds often cause nausea, pain meds often cause itchiness. So these are our adjunctive drugs that can be used to help with those side effects. So there's no effects afterwards. And it's fine for the like lactic acid. It makes you aware of what's happening while you're inhaling, but then once it's gone, it's gone. So a lot of cases use nitrous oxide. All right, regional analgesics and anesthetics. Regional anesthesia usually involves placement of anesthetic in the epidural or the subthoracic space. Intrathecal narcotics are given by injecting anesthetic drugs to the baby nerves as they emerge from the spinal cord. Your spinal column, or all of your spinal fluid is not directly being injected. Okay. The medication is going just below, and it's going to exactly bathe the nerves as they're emerging from the spinal cord, which causes that decreased sensation or loss of sensation from the waist down, depending on whether you have a spinal or a neural. So the spinal cord and nerves are not directly injected. Our analgesics block pain and anesthetic both pain and motor response. So it's nursing's job to monitor the woman's responses to what she's been given, whatever analgesia and anesthesia she's been given. in her labor and delivery, discomfort if she chooses. So we're going to go over types of anesthesia for childbirth. We will circle back to this video depending on timing. So here, I know you guys haven't had like neuro yet. Here's where your okay. They put in a spinal. A spinal is usually a one-shot deal. Okay, they just inject the medication and they will give a spinal for repeat C-sections or scheduled C-sections, something where they know I need this person numb for 2 or 3 hours, maybe even less, and that's it. An epidural is placed much lower, and with an epidural, it's similar to an IV, so there's going to be a catheter that stays in the back. Okay, a thin, flexible catheter. Because you may be in labor for 3 hours, you may be in labor for 3 days. Okay, they want to have access to continuously give medication to that epidural catheter for as long as they need to. Okay, but you'll see both these are very far away from the actual spinal cord ends. If you have an epidural, if you're going to have an epidural, and something occurs, you need to have a C-section, the epidural is fine for that. They adjust the medication that's going in so that you have appropriate anesthetic for the C-section. Okay. So the epidural space is a small space just outside of the dura. The epidural space is penetrated with a large needle, and a fine catheter is threaded into the epidural space. They give a small test dose in the catheter to make sure that they're in the right spot. Okay, if there's no effects, if the mom doesn't notice anything, they're in a good spot and they'll continue with the epidural. If she has any like numbness around her mouth or ringing in her ears, then they're not in a good spot and they need to try again. Okay. Redirect. Usually not administered until about 4 centimeters dilated. Okay, just because it can slow down, these can slow down the labor process. Okay, with an epidural, local anesthetic drugs are usually used. So they will give a little tiny bit of fentanyl with something like lidocaine, which actually does the numbing. Okay, and they can adjust how much numbing medicine is in versus how much pain medicine is in. Okay. So if somebody has more pain, less numbing, and they may still have some sensation, they may be able to ambulate even with it. Some make a lot of numbing medicine and feel absolutely nothing. Some there is that. So usually the epidural, the drug can constantly happen. Even with epidurals too, when it comes time for mom to start pushing, they may back off on some of the numbing medicine so that she can sense the urge to push and feel the urge to push. Okay. The dura lies just below the tiny epidural space. If it's punctured accidentally, that is called a wet tap. And what can happen is spinal fluid can leak from that hole, which may result in something called a spinal headache. Okay. This is not detrimental. If you have to have a spinal tap done, this is what they do. They spinal headache. We'll talk about what we can do for that in a little bit. It cannot be used in women who have abnormal blood clotting, an infection of the area, or low blood volume, hypovolemia. Adverse effects. Most common side effects are maternal hypotension and urinary retention. But priority evaluation should be mom's blood pressure. Sure, we want to know if the bladder's filling up, right? She's not going to be able to feel below her waist. She may not know her bladder's full, but it's not going to fill anything. Okay. So, check mom's blood pressure. Right, I mentioned a little bit ago, sometimes they don't feel that urge to push. when it comes time to push, so they can either back off on some of the medications that they're giving in the epidural, or it might just result in a longer pushing stage. A spinal block, or a subarachnoid block, the dura is punctured with a thin spinal needle, so they intentionally go into the dural space. They can place it with spinal fluid. Now, the difference is that this needle is much smaller and thinner, so it heals faster, the spot where they puncture. Local anesthetics injected, they use a very small amount, they only need a small amount, and anesthesia happens very as someone who's had forced restrictions, like your legs are dead weight before you can even put them on a table, before you can even lay back down. They have to literally lift your legs up. And you cannot feel anything from the waist down. You lose all movement and sensation below the block, and the effects last longer than with an epidural. So it's a one-shot deal. And like I said, they'll use this for things when they know, like a repeat C-section or a scheduled C-section, when they know that they only need the mom numb for a certain amount of time. Some people can use it for that too. Okay, limitations are the same as they are with an epidural, so abnormal blood clotting, low blood pressure, and infection. Okay, our adverse effects are hypotension and urinary retention, same as with an epidural. That spinal headache can sometimes occur. So with the spinal headache, through your spinal column, right, through your spinal cord and around your head, your cerebrospinal fluid, around your brain. So if you are losing spinal fluid, if they accidentally puncture that dural space and spinal fluid is leaking out, the best way to help is laying that mom flat. Okay, if she's sitting upright, more of that fluid is going to drain out. So laying her flat will help with any spinal leak, any spinal fluid leak. Other ways to help a spinal headache, the same things you would do if you had a regular headache. Bed rest, rest, analgesics, fluids, IV fluids and oral fluids. Not that we would have IV fluids for a headache, but think of it the same way. Okay, fluids, rest, analgesics. If none of that works, there is a procedure that can be done called a blood patch procedure. And I think it's kind of cool. They take, it's like 10 to 15 mLs. Yeah, 10 to 15 mLs of the mom's blood. So they'll draw it right out of her arm. And they inject that 10 to 15 mLs exactly where they did the spinal or pain meds will hopefully help. But if not, they have this as a backup. There's only 5 slides left of the chapter, so I'm just going to finish it. If we go a little past the break time, I'll make it up to 1 minute. Okay? It doesn't make sense to stop first. There's not much left. Local and pudendal blocks. These are, similar to anesthesia at a dental office when you have a root canal or cavity filled. It's administered in the vaginal perineal area. Local infiltration. No medication risks as long as she's not allergic to what they're giving her. Pudendal blocks, we don't really do these anymore because we have epidurals, but they essentially inject the pudendal nerves on either side of the mom's pelvis. They go right in, vaginally into the pudendal nerves on either side of the pelvis. So they're very long needle. It does not block the pain from contractions. It will only help with, like, if they're using forceps or for episiotomy. Adverse effects include vaginal hematoma or abscess or an allergic reaction. General anesthesia, very rarely used. Okay, putting somebody to sleep. Exceptions would be something that is a true emergency, like a true emergency, and there's no time to do a spinal epidural. Like they have to Mom doesn't have a spinal or an epidural already, we have to put her to sleep. Or if somebody has a contraindication to a spinal or epidural, which is all patient general anesthetic, for constant anesthesia, minimal fetal effects, and prompt maternal awakening after the drug is stopped. They're awake before they're wheeled out of the operating room. They can recover with their baby in the recovery room. Adverse effects in the mom, major risk is the same during birth as it is any other time they're doing general anesthesia. They want you to be NPO, right? Anytime you know you're going to be under general anesthesia. You your lungs, right? And it gives a little bit of space. If you have something in your stomach and you aspirate a little bit, and any of that gets into your lungs, you end up with aspiration pneumonia. So that's why it should be NPO. You can always plan this for an emergency C-section. That's one of the adverse effects of the baby. Get that baby out quickly. Respiratory depression is the main risk because the baby's getting everything the mom gets. So very trying to reduce the time from mom to sleep to getting that baby out. They're going to be sleepy. All right, the nurses focus on nutrition, questions regarding allergies to foods, drugs, latex, what they're doing, what their plan is for pain relief, all of those things. Keep the side rails up, especially if they've gotten narcotics, it can make them dizzy or drowsy. Help hold the mom in the correct position for the spinal or epidural. What do you think you need to tell them is happening when you're holding her? Why are you holding her? You're holding her in the right position. You're going to tell the anesthesia when a contraction is coming, right? Because they're about to go in with a needle. They want to know when that contraction is coming so that they cannot go in with that needle until the contraction's over. Because mom's probably going to want to move. So you got to tell them when that contraction is happening. Provide education regarding the procedures and expected effects. Reinforce explanations given by the anesthesiologist. You know, they come in and blah, 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 and then they leave. And you have to reinforce everything that they say. Prevention, respiratory depression. Again, you may coach the mom on when to start pushing and not pushing because if she can't feel, she's not going to know when she's having a contraction. 5:50 on the nose.